One of the hardest parts of residency that no one teaches you is how to think through these high acuity agitation situations in real time. So you are on call and you get a consult from the ED. They're saying that there is a 29-year-old male brought in by the police after threatening strangers outside a gas station. In the room, he is pacing, yelling, paranoid, diaphoretic, refusing vitals. Pause the video here and ask yourself, what are your first three actions? So your job, first and foremost, is safety. You need to make sure that you are safe, your staff is safe, and the patient is safe. We're going to go into how to do that in just a little bit. Your second job is to identify the likely cause of what is causing this agitation, because if you pick the wrong cause, you're not going to get the medication right. Then after you identify the cause, figure out what medication to use, and you got to do this quickly because this patient can be aggressive. If you choose the wrong medication, it can actually worsen the situation, which is why we're going to discuss how to figure out what's driving the agitation and what the proper medication is to treat. Before you enter the room, it's important that you scan the risk. This is going to help with safety. So ask, is there anything that can be used as weapons? What is the number of staff? Is security nearby? You want to stand at an angle with this patient. You need to not look confrontational, and you need to have a clear exit path. You do not want to get cornered. Again, safety is number one priority. Keep yourself closer to the exit than the patient so that they cannot block the way. You do not want them to feel cornered because they may lash out. You need to know how to de-escalate a situation because de-escalation is a clinical intervention. So you want to start off with short sentences because agitated patients cannot process long explanations. You want to validate their emotion. You can say something like, I see you feel unsafe. And that is different from validating their delusion that, yes, the nurses are poisoning you. You also want to offer them choices because agitation often worsens when the patient feels trapped or powerless. Watch your tone because they will pick up on if you are agitated with them. So you do not need to do a full medical workup before calming an unsafe patient, but you do need to do a rapid medical screen if it is safe enough to do so. And this not only is going to let you know if there is a medical emergency, but it's also going to help you figure out what is causing the agitation. So for your focused initial assessment, you need to look at vitals if safe enough to do so, oxygen saturation, mental status, and attention. This is going to let you know if this is possibly delirium. Brief neurologic screen, again, if safe. Know their medication and substance history. If you're not able to get it from the patient, then getting collateral from EMS, police, family, and nursing can be very helpful. Again, if safe enough to do so, order labs. A UDS to see if drugs are causing the agitation, alcohol, because alcohol intoxication can also cause agitation, CBC, you're going to be looking for signs of infection, and then the CMP to look for liver, kidney function, possible electrolyte disturbances. You also want to get a point of care glucose because hypoglycemia can also cause agitation. So as you're performing your initial assessment, there are some major medical causes to keep in mind. A huge one is delirium. If a patient is elderly, this should be number one on your differential. These patients will have fluctuating attention, disorientation, and they may even have visual hallucinations. If you don't already know, visual hallucinations are more associated with medical causes, and auditory hallucinations are more associated with primary psychotic disorders. Look for signs of infection, such as fever, elevated white blood count. Look for electrolyte abnormalities, renal hepatic failure. All of these things can cause agitation that you do not want to miss. Hypoglycemia and hypoxia can also cause agitation, which is why you get a point of care, glucose level, and oxygen saturation if safe to do so. Withdrawal is another one that you do not want to miss because alcohol and benzo withdrawal can be deadly. Look for tremor, tachycardia, hypertension, diaphoresis, seizures. If possible, get a history of their use and know when their last drink was. Substance intoxication with stimulants, alcohol, PCP, synthetic cannabinoids can all cause agitation. So you want to look out for dilated pupils, nystagmus, hypertension, tachycardia. Get a UDS if possible. There are also neurologic causes of agitation. So you want to look for a history of head injury. If you can get a CT, look for a brain tumor. Seizures can cause a postictal state where patients are agitated. You might see focal deficits. If they have a history of antipsychotics, look out for NMS. If they have a history of antidepressant use or NMDA use, look out for serotonin syndrome. Malignant catatonia, all of these can cause agitation, and you do not want to miss these medical causes. So let's say that you're consulted by an internal medicine doc about a 68-year-old patient with a history of schizophrenia who was admitted to the hospital for a UTI. Now he's yelling that the staff are trying to kill him. He's pulling out his IVs, trying to climb out of bed. He's disoriented, even worse at night. What do you want to ask yourself and what do you want to do? What points to that this is delirium versus psychosis? What should you do before even starting the medication? And if he remains dangerous, what medication class is reasonable? Pause this video, answer the questions, and then continue to see if your thought process is right. So this person, even though they have a history of schizophrenia, they're older in age, they have a UTI, which is the common cause of delirium, they're admitted to the hospital, they're disoriented, nighttime worsening. This sounds like delirium versus a primary psychosis. So how do we treat delirium? You want to reduce stimulation, you want to reorient the patient. If they have glasses, make sure they have their glasses, make sure they have their hearing aids. If family or a sitter is available, have them sit with them. You want to treat the underlying cause, so treat the pain if pain is a contributor. Treat urinary retention if they're constipated. If they have the infection, give them antibiotics. And then check their vitals, make sure that they're not becoming septic. If reorientation does not work and the patient is a danger to themselves or others, short-term antipsychotic medication may be used to reduce the dangerous agitation while the medical cause is being addressed. Use a low dose of the antipsychotic, reassess often, and stop when no longer needed, since antipsychotics can cause severe side effects in the elderly. You also want to avoid them or be very cautious in Parkinson's disease or Lewy body dementia due to the sensitivity to the dopamine blockade. You also want to make sure that you avoid benzodiazepines in delirious patients. Benzos can actually worsen confusion, disinhibition, and it can cause falls and respiratory suppression in delirious patients. Exceptions would be alcohol withdrawal, benzodiazepine withdrawal, and catatonia. These are actually treated with benzos. So when you are giving medications to an agitated patient like this elderly patient, when do you give the medication as a pill and when do you give it as an injection? You should offer the oral medication whenever it is safe to do so. And the oral medication just preserves alliance and avoids restraint when possible. Even in patients with psychosis and mania, oral antipsychotics are often appropriate if the patient is willing to take them. Explain to the patient the goal. The goal is less distress, more control, safer assessment. That being said, I have offered patients in the past, do you prefer a pill or do you prefer the shot? And they're like, I prefer the shot. So if they prefer it, give the shot. And sometimes the IM injection is necessary. You do need to escalate if safety requires it. If this patient is at imminent harm, they're having assaultive behavior, throwing objects. If you're unable to redirect them, they're refusing safer options. If they need immediate medical care and you cannot safely proceed without calming them down, you do want to use the least restrictive, effective intervention, and sometimes that is the injectable. Sometimes even IM meds don't work. And when this happens, we start thinking about restraints. Now, restraints are a medical legal risk, so you should only put a patient in restraints when absolutely necessary. So the indication of putting someone in restraints is when they are imminent danger to themselves or someone else when less restrictive measures are ineffective or not feasible. So when you're thinking about putting someone in restraints, you want to think about what alternatives were already tried, why now, what is the plan to remove restraints. For my hospital, we have to reassess every 4 hours to see if they need continuation of the restraints. And how will you monitor? How are you going to make sure that this person is safe while they are in restraints? You also need to document very well because this is a legal risk. And choices, think about, can the patient participate in care? What is the most likely cause? And what medication risks does this patient have? Can they cooperate? Can they swallow? Then use oral medication first. The goal is for them to be calm, not unconscious. However, if they're unsafe and cannot cooperate, IM medication may be necessary and have monitoring and staff ready because things can go wrong. For imminent danger and meds are not working, restraints may be required. In this case, you can continue to use medication and continuous reassessment to make sure they are still requiring restraints. Document well. So let's test your decision making. You get consulted on a 45-year-old admitted for pancreatitis who is now tremulous, diaphoretic, tachycardic, hypertensive, and he is trying to leave. He says bugs are crawling on the walls and he wants out of there. What should you be thinking about? What is the most likely driver? And what medication is first line? Pause the video and then you will see the answer when you continue. So the answer is alcohol withdrawal. This person is admitted for pancreatitis, which is commonly associated with alcohol use disorder. He's saying bugs are crawling on the walls, which indicates that this is a medical cause of hallucinations, and he has all the autonomic instability that you would associate with alcohol withdrawal. So as far as medications to treat, you want to treat this with benzodiazepines. This is the only type of delirium that you will be treating with benzos. Part 2 will be coming soon, where we discuss specific medications for agitation. If there is something you want to learn but we didn't cover, suggest it in the comments below, and subscribe for new videos every week.